Good evening. Hello. Welcome to the Dentsply Sirona Implants webinar. My name is Martin Wanande, and this evening I'm going to be talking to you about the 3 Bs of planning, placing and restoring full arches. I'm going to talk you through how when you're planning your full arch restorations, set the considerations of bone volume, biomechanics and your patient's budget are things that you need to plan around and look at. We're also going to talk about lots of different implant solutions. There's going to be a mixture of cases as well as a little bit of literature to help you along this evening, but it's mainly going to be case-based and showing you the different solutions that we use in practice. I'm based here in London in the United Kingdom. Thank you very much for those of you logging on. I've a look at the 500 odd people that have logged on, and you've logged on from all around the world. And thank you very much. Please feel free to ask any questions. I'll get to as many of them as I can at the end of the webinar. The aim of the webinar today is to talk to you about how you can treatment plan full arch, fixed, supported, bridge and denture implant cases, and to understand the difference between many solutions. I found when I began this journey there were only 2 or 3 solutions I'm aware of, yet there's a whole plethora of things that you can do to treat your patients. And I think when you're talking about full arch cases, you really have to talk about immediate loading. So we're going to go a little bit through the theory of that, and so you can understand how immediate loading works and why we can use it for full arch cases. What we know is that in and around the world, there's a large proportion of our patients, our implant patients, who are missing teeth, and there's a large proportion of them that are edentulous. We know that as we have an aging population here in Europe, you have probably a younger population around the world, but we know that our population that's aging is going to require more and more full arch restoration. So if you have a look, this is recent data from the WHO that talks about the proportion of patients who are edentulous. We also know there's a link between function and health, and there's some well-documented studies that talk about the chewing ability, and we know that people who cannot bite and chew properly tend to not to be able to digest their food as well, and when they tend not to be able to digest their food as well, we find there are more medications that are affecting them in order to help them digest their food and also to be able to keep their gut guts healthy. We also know that people who lose their teeth, there is a connection between tooth loss and psychology. We also know that there is the psychology of tooth loss is something that's well worth looking at if you are looking to provide this sort of treatment to patients, because understanding the psychology of the people you're dealing with is key, I think, when you're dealing with full arch cases. It's also now, it's better and better documented evidence between the connection between heart disease and periodontal disease, and it's something we urge all of our patients to look at and to be aware of. So there are different kinds of dentures available, and if you are making implant retained dentures, one of the things that process says that it's worth being aware of is something called injection molding. And injection molding is a method by which the denture is flasked, and as it's flasked in this machine, this particular example is made by Ivoclar, as it's flasked in the machine, the warm acrylic is put into and flasked into the denture base, and once it's flasked in, the actual denture base is heated as well. The heated denture base allows, basically, this allows us to compensate for polymerization shrinkage, and this means you get a better fitting denture. If you look at what we can do for our patients, I always think that implants are a little bit like what we can do for the lady in the wheelchair. They're not quite like giving her her teeth or giving her her legs, but they're as close as we can do with science in order to allow our patients to function correctly. And I think especially with full arch cases, you do meet people who are dentally crippled, and you're able to restore them in a way that restores their function and health in a way that really, really does benefit them. The main reason for doing this is this question comes up a lot. How many implants do you need to restore a full arch? There's lots of examples you can see from around the web where far too many implants have been used, and the advantage of this, I think, can be financial to but the disadvantage can be the cleansability. of some of these restorations. So how many implants do you need? Obviously, these are four cases where probably too many implants have been used. And these are some cases where slightly fewer implants have been used. I was very lucky to go and see this gentleman at work in Italy, and he uses 2 implants to restore his full arches, which is pushing the envelope for fixed teeth, certainly. And you can see an example of 1 implant locator in the center line. That's a case where that has been used as a temporary implant during the grafting procedure. But this isn't really, this is pushing the envelope the other way. The guidance on how many implants can be found, if you have a look at this, this is the ITI, and this plan showing how many implants you need for the maxilla and the maxilla and the mandible allows you to plan effectively. And if we have a look at fixed full arch restorations, the options we have are as such these. So you can have, for a fixed prosthesis on the maxilla, you can use 4 implants, you can use 6 implants, you can use 8 implants. And the advantage with 8 implants is the bridge can be split into 4 separate bridges. For the mandible, you can use 4 or 6 implants, and you can achieve very good results with those, so your patients can function fine. For removable restorations, in the mandible, you can use 2 implants with a telescopic attachment or a locator. You can use 2 implants with a bar. You can use 4 implants with a telescopic attachment and 4 implants with a bar. On the maxilla, you can again use 4 implants with some sort of telescopic restoration, 6 implants again with a telescopic restoration, 4 implants with a bar, or 6 implants with a bar. So you can see that there's a huge variety in terms that you can offer your patients in terms of fixed and removable restorations. And if we go a little bit further, and you have a look at the different options for the maxilla and the mandible, you can see in the mandible you can need a minimum of 2 implants, a maximum of 6 in most cases, and in the maxilla a minimum of 4 and a maximum of 8 can be used in order to restore a full arch. So with this variety of different options, what is it that you will look at when you're assessing your patient to see which one of these options are suitable? We're going to look at bone volume. We're going to look at the biomechanics that you're going to look at with your patients. We're also going to look at the budget and how much these different options cost to your patients. We can't talk about full arches without discussing immediate placement. And immediate placement works using this theory. If you look at the green curve that shows you the total stability required, and you'll look at the curve for total stability, and you'll have a look at the curve for primary stability and also the stability due to integration. When implants are first placed, we've got a high primary stability. This is due to the shape of the implant, and we've got a low stability due to integration. As the implant integrates, the blue curve increases and the amount of stability due to integration increases. As this happens and the bone remodels, the amount of stability due to primary stability reduces. This means that if we look at the overall curve for total stability, we know that if we can keep the primary stability of the implant above a certain critical level, this is determined by the primary stability as well as the speed of integration. The total stability means we're able to load implants immediately. We know that the critical time is between week 2 and week 6, where the total stability drops of the implant drops. We know as well if we splint the implants together, this increases the rigidity of the restoration, which means the chances of losing an implant are reduced due to the lack of micromovement due to splinting the implants together. We know that when we're dealing with implants, we have to go through a stage whereby we plan aesthetically. Having planned, we plan functionally what the restorations are going to look like. We also treat and clear any pathologies, periodontal disease and caries before planning on the initial provisional restoration, and then planning where we're going to put the implants based on CT scanning as well as diagnostic working. And in the traditional way, we would then extract the teeth, and having extracted the teeth, we would wait a period of time for healing. Having waited for healing, we would then proceed to carry out any grafting, and after a further period of healing, we would then place the implants and then let the implants integrate during the healing process. Having let the implants integrate, we would then expose the implants. Having exposed the implants, we would then take impressions. Having taken impressions, we would then verify the impressions. Having verified the impressions, we would then try-in. We would carry out some sort of aesthetic and functional try-in. Having carried out that part, we would then put a provisional restoration and a final restoration in. If we run through the immediate extraction, placement, and restoration process, we're missing out several crucial stages by planning quite heavily at the start of the process. It means that we miss out some of the provisional restorations and some of the healing time, and crucially some of the bone grafting stages that we would do. And in the restoration stage, we would take a full arch impression. We would verify that before some sort of try-in of the final, and then some sort of final restoration. Now, how does the bone volume affect this? We know that when we treat cases where we have a lot of bone volume, such as this one, we're able to place the implants, and we're able to place the implants upright. And this is the case where we've used 6 implants. We've immediately loaded them. There's a rigid bar to connect the implants. And when we've done this, what this has allowed us to do in a case with ideal bone volume is to restore the implants in the ideal place, and also to place the implants with a wide A pre-spread from the 6 to the 6. We can sometimes use surgical guides and CT-based planning in order to help us. And this is a case where we've carried out some CT-based planning. We've made a surgical guide, and with this, we've been able to place the implants in the ideal position. Sometimes when we don't have enough bone in the right place, we might carry out some bone grafting. We can use bone, we can use biomaterials, we can use a PRGF as well. These are all options that allow us to increase the volume of tissue. What I'm going to show you now is a case where we've carried out the traditional method, and we've carried out bone grafting, and we've gone for 8 implants. I'm going to speed quite quickly through these cases, so hopefully you'll get a good overview of the things that are possible. So this is a case where we started off with a patient with a failing terminal dentition. This is the patient at presentation, and having presented, we've carried out an OPG and carried out some CT scanning and planning. We've decided to do this as a delayed approach. So the initial approach has been to, first of all, to treat any caries and pathology, to remove any infected teeth, and to make some sort of provisional restoration. During the healing stage, we have then made some sort of provisional bridge to hold on the teeth that are remaining. And this provisional bridge has allowed us to wait for the healing stages to happen. And during this phase, we've carried out our further CT-based planning. This has led us to understand that actually in the 6 areas, where you can see in this slide here and this slide here, we don't have quite the bone volume in the sinus area in order to be able to place an implant in the 6 regions. Having looked at the choices, what we've decided to do is to carry out some sinus augmentation. So what you can see now is the patient having healed for around 6 months with, again, just healed ridges in all of the areas that we're working on. Now, again, what we've done at this stage is we've carried out some sinus augmentation, and this has involved getting access to the left and right maxillary sinuses. And when we've done this, we've been able to place implants further back in the mouth, as well as place implants in a delayed situation in the centrals and the 4 areas of this patient. This is the implants having integrated, and what we've been able to do at this stage is then connect and load up some of the implants once the implants have integrated. And once they've integrated, we have placed a provisional bridge. We've had to modify this bridge and change it by sending it back to the laboratory before we get a better fitting provisional restoration. And we've used this provisional restoration. Having used this provisional restoration, we now have selected some abutments, and with the abutments, we have then gone through the fabrication of provisional and then final bridges. So these are the provisional bridges. These are CAD/CAM milled abutments that we've used in this case. And having used those, we've been able to restore the patient using 4 separate bridges and 8 implants. And the final result that we've been able to get for the patient looks something like this. The final result for the patient has meant that we have been able to restore him from this to this state over a period of time. That's the traditional approach, where what we've done is we have used 8 implants in a delayed approach to restore a full arch. This is the final bridge in place. That's the start and that's the end of the restoration. Now, we can use tilted or angled implants. And what this means is the tilted or angled implants mean that we're able to avoid sinus grafting. So in the maxilla, what we're able to do is, I've shown you a case. The first case I showed you where we're able to put 6 implants in the correct position, most without having to use any cantilevers. But using tilted or angled implants means that it avoids the need for sinus lifting. In order to be able to place implants in the first molar areas, we would have had to carry out sinus augmentation in the maxilla, place 8 implants, and having placed 8 implants, we'll be able to get a final restoration that goes from the first molar to the first molar without using a cantilever. But using angled implants allows us to reduce the amount of cantilever, avoid augmentation in and around the sinus area. And this means that we can carry out some immediate loading. In the mandible, using angled implants allows us to reduce the cantilever. Where you see the orange and the red lines is the amount of cantilever, and where you see the yellow lines there, that represents the amount of cantilever present. Using angled implants reduces the cantilever from where you see the orange line in the picture on your right to where the green line comes up. So we've reduced the cantilever and we've been able to extend the restoration further back by tilting or angling the implants. We know that there's very good evidence for this. Mallow, in 3 studies, looked at 5, 10, and 7-year outcomes. And what he discovered is when he looked at 10-year outcomes, he's placed a large number of implants in this 2011 study. He's got a high prosthetic success rate and he's got a high implant success rate. So we know that this approach works and can work well in the right circumstances. It does require the use of angled abutments. These angled abutments allow us to correct the angulation when we place tilted implants. What you see here is the Dentsply implants SmartFix concept, whereby angled abutments are used in order to be able to place angled implants, and these correct the angulations for the prosthesis. You'll see this a lot in the presentation later on. This is a case where we've used angled implants. This is the patient at presentation, and this is obviously he's wearing a denture, and you can see there's many missing teeth. He's got a deep bite, he's class 2, and he's got a failing dentition whereby only the upper left one is the only viable tooth that we can use. What you can see on the initial radiographs is, again, a failing dentition apart from the upper 6. So what the treatment plan has been is to remove the remaining upper teeth, to use angled implants, and to immediately load on the day. This is the planning that we've carried out, and you can see the 4 angled implants in place. And what we've been able to do is on the day, remove the teeth, place the implants, put some sort of splinting or retention bar in place, and that's on the day of loading. We've then gone on from that stage to begin by reviewing him 2 weeks later. And you also have to, again, assess your patient's bites when you do this, and I'll mention a little bit about how we do that using digital smile design. This is the patient at the end of the process with a fully restored mouth. So again, this is something that works and you can use on your patients regularly, and you use the angled implants in order to avoid augmentation. In this case, as you can see, we've managed to give him a shortened dental arch from the 5 to the 5 on both sides. And this is the case before and after. You can see we've got a nice aesthetic result that's aesthetically pleasing to the patient whilst being able to load the implants immediately, so he hasn't had to go through a denture stage. We can, where there is a lack of bone, again, one of the options we have is to use zygomatic implants. Zygomatic implants are basically anchored in the zygomatic arch, with part of the implant in the zygomatic arch, the other part in the maxilla. And when we're able to do, the other choice that we're able to use is pterygoid implants, where they're placed within the maxilla but close to the pterygoid plate. The other option we've talked about is using angled implants as well. This is a case where we've used some zygomatic implants, and we've used the zygomatic implants in order to be able to place implants in areas where there is a lack of bone. And again, we've been able to immediately load this case and place the implants in an area where we're able to restore them. This is the patient before, and that's the patient afterwards. So again, sometimes when the patients have a lack of bone, you can use bones outside of the mouth in order to be able to attach the implants. So that's start. That's going through the process with the immediate. That's the immediate caries removal and pathology removal stage. Those are the zygomatic implants in place. That's at a bite review stage. That again is a provisional restoration at review, and that's the final restoration in place. How about the biomechanics of the different solutions? We've talked about two implant locator overdentures. We've talked about full arch bridges. What is the difference in the function that the patients get from these two options? When we look at the different options, one of the papers that's really useful, I found useful, is a new paper that's coming out, and it's comparing complete dentures to bar overdentures to telescopic overdentures. And when this paper looked at the chewing efficiency and the maximum bite force that could be generated with the different options, they discovered that the telescopic overdentures had higher chewing efficiency and a higher maximum bite force than bar overdentures, than complete dentures as well. And again, this is a paper that looked at the myographic activity that you got, and it could complete dentures to implant overdentures, to implant fixed partial dentures, to dentate patients. And when they looked at this, it's a meta-analysis where they initially started off with 646 titles, only 16 met the inclusion criteria. They actually looked at the muscular activity, and they discovered, quite interestingly, that if we looked at the clenching and the chewing force that could be generated, complete dentures are the lowest, followed by bar overdentures, followed by implant fixed partial dentures. But when clenching, dentate patients are able to clench the hardest. But in terms of chewing, actually between the dentate patients and the implant fixed partial dentures, the patients with implant supported restorations are able to exert much higher chewing forces. In terms of budget, one of the options that would prove quite useful to your patients are these durable restorations. These are long-term provisional restorations that are possible. Now, these are possible using this system. This is the Weld1 system by Dentsply. This is Marco De Gidi, and it's using resistance welding. And this welding unit, what you're able to do is produce rigid frameworks. The rigid frameworks have two big advantages. One is that by splinting during the healing phase, so during week 2, between week 2 and week 6, and this increases your chance of success and lowers your chance of implant failure. It allows the construction also of a more rigid framework. It also allows the construction of a much more durable restoration on the day, with the added advantage that when you do this, you can preserve bone rather than remove bone in terms of when you place your implants. He has lots of evidence where he's looked at the different parameters and the different options for welding. This is a case where we've used durable restoration. This gentleman has shown up, and he has a failing dentition when we have a look at it. And this is just some of the assessment we do when we see our patients. This bridge is failing on this side, that bridge is failing, and it's really just these two teeth in the arch that are viable in any way, shape or form. That's the lower arch in place, and that's his upper smile. We've done a little bit, I'm just going to skip through these slides. We've done a little bit of facial analysis, and we've discovered that when we've analyzed his face, basically his jaw is canted and his teeth are canted. And by looking at how we reconstruct his teeth without having to carry out osteoplasty with this part of his jaw, we've been able to begin the reconstruction process. Once we've removed the bridges, once we've carried that out, we're then able to place the implants immediately, which you can see here in situ. Once we've placed the implants, what we're then able to do is connect up the abutments, and what you can see here is the Dentsply implants component. This is called the SmartFix abutment, sorry, the balance-based angled abutment. With that, we put the welding components on, welded a framework, used a shell, picked the shell up in the mouth, so that we've been able to construct on the day this provisional restoration. These are what are known as durable restorations. They're meant to last a little while in the patient's mouth. And the advantage for the patient is you can spread the budget between the provisional and the final when they're having their restorations made. This is the durable restoration in place on the day. This is the post-op OPG that you can see on the day. And again, 4 implants, one angled so we need a 30-degree abutment, and the other's reasonably straight. And that's him a week after he's had the restorations. What are the other choices? We've talked a lot about fixed, and we've talked about fixed, and you've seen examples where we've done fixed bridges with 8 implants, with 4 implants and angles. We've loaded them immediately. There are the options of making removable prosthesis, and one of the things that I learned about a lot is fixed, that I quite like using in practice, are fixed removable prostheses. This is an example of a 2-in-1 bar. And what we're able to do with these bars, which I'll show you the reconstruction we did on the lower jaw for this gentleman, is we're able to, in this case again, similar sort of assessment. This is the treatment plan, is to remove the teeth, place 4 implants in the upper jaw and 4 implants in the lower jaw. He would like something that is cleansable. So on the lower jaw, what we're going to do is use a fixed removable prosthesis. So this is planning that we've carried out for the 4 implants. We're going to need to use an angled implant on the upper there, and on the lower we unusually have enough bone volume above the ID canal to be able to put the implants in without needing to angle them and to get good AP spread. We've removed the teeth and placed the implants. We've used the welding unit. Having used the welding unit, we have then welded the top. We've welded the upper framework together. We've removed the implants on the bottom, removed the teeth on the bottom, placed the implants. Having placed the implants, we've welded them together. We've welded the abutments together. And this is the provisional restoration on the upper, and this is the provisional restoration on the lower. Now, we've carried out from here, we've started the process of reconstructing the lower. That's it at the end of surgery. The process of reconstructing the lower has involved going from this to this. And we start off with some abutment level impressions. And these abutment level impressions, during this, what we do is we splint the impressions together. We splint the impression copings together. We then construct from here a verification jig and a bite registration. This is the same process that you do whether you're carrying out full arches or whether you're carrying out overdentures. It's making a framework. The verification jig is then tried in the mouth, and once we've verified that the model we have is accurate, we've taken a bite registration. What I quite often do is take, in this case I've softened the wax, you can use bite registration material. From this, what we've constructed is this part here. What you can see here is this is a screw retained try-in. The screw retained try-in again can clip over and around the bite for the verification jig, but this gives the patient an idea of what they're going to look like with everything in place. So that's the verification jig, that's the bite registration, that's the try-in that we've constructed there. That's the patient with the try-in in place. A few changes have been needed. We've carried out the changes, and what this has meant is we've been able to then go digital. What this has involved is scanning the model, scanning the try-in, and from there constructing the primary bar, the secondary bar, and using the tooth positions from the try-in to be able to determine where the teeth are going to go and how we're going to support the teeth. From here, what you can see is the primary bar, the secondary bar. That's the digitized, that's the try-in in place, and those are the abutments that you can see there. And with this, we've been able to design where everything goes. We've been able to digitally design the shape and the shape of the retention bar. These are the retention bars when they come back, and the primary bar is going to fit into the mouth and be screwed on. The secondary bar is going to have teeth built onto it, and this will be fit into the mouth. So this is when the secondary framework has had the teeth built onto it. You can use attachments such as these, and these attachments there fit into and lock the bar in place. Quite often the patients don't need this because the profile of these bars are quite thick and square, and this means that you don't get lateral movement, and this means that the patients are very, very comfortable during this stage. So this is the fitting. What you can see here is the abutment level. That's the primary bar in place. This is the final framework in place. And you can see how we can go from that stage at the beginning to this stage at the end. Those are still provisionals on the upper jaw. And the step-by-step from the lower is to start to basically treatment plan where the implants are going to go, to construct some sort of provisional restoration. From there, to then take an abutment level impression to splint the impression copings. This is Duralay that we've used. This is light cured pattern resin with some floss to help guide it. From that, we've then had a master model made. We've verified that the master model is accurate. We've then made a screw retained try-in. From the screw retained try-in, we've then digitized the screw retained try-in. We've then constructed the primary bar and the secondary bar, and then these have been used. These have been used to make the final prosthesis for the patient. There are different bar designs that you can use. What you can see on these bar designs here, that's a 2-in-1 bar which we've described, which has a well-fitting primary and secondary framework. Here you can see different other bar designs, which are Dolder and Hayder bars. All sorts of different attachments can be made. In fact, with what I'm going to talk you through is a case with a Hayder retention bar. But you need to bear in mind that all of these types of bars, which have slots, which have ball attachments, which have locator attachments, which have Brexit-Horrocks attachments, there's lots of different attachments, locks and swings that can be designed into these CAD-CAM bars. This is the case where we've used a Hayder bar, and this again is a slightly more cost-effective option to your patients because this bar can be constructed fairly cost-effectively, and it fits onto these 3 yellow attachments that you can see into the denture there. And in the mouth, it can be attached with the bar attached first, the denture attached second, and this gives a nice result for the patients with a reasonable amount of retention. This is obviously an option which gives less retention than the option we've spoken about before. There is another thing which we use commonly, which is conometric or telescopic retention. What this relies on, it relies on friction fit. Friction fit means that the abutment and an attachment above it, there's a 5-degree taper between the two, which means you get a snug fit where it locks into place. And if you have 4 of these in an arch, then you get very good retention from the 4 of them. And that telescopic retention allows us to basically to keep crowns, bars, and abutments in place. We can use this to retain dentures, and I'm going to show you a couple of cases where we've used this attachment to retain dentures. There's different angles of abutment that we can use, and there's also different heights, and it's using these components there. Using these components there, we're able to hold everything together and hold the denture. What we're able to do is with different heights of abutments and different angles, we're able to hold these retention bars in place. We can use them as delayed loading or immediate loading. This is a lady who started off with a failing lower dentition, and with a failing lower dentition, we have removed the teeth. We're planning on removing the teeth, and with this, we've removed the teeth, and on the day, we've connected up abutments, and we've been able to line up these telescopic attachments, and also restore her on the same day to give her this as a long-term provisional restoration. So you can use this on the lower jaw with 4 different ways. You can use CAD-CAM in order to make these, and the CAD-CAM allows you to line up and angle the abutments without having to do that intraorally. This can be done via computers, and it makes the whole process much more easy. And you've got a combination of different caps you can use. So this is a case where we have started off with a dentureless lower jaw. We've carried out the planning, and having carried out the planning in a CT-based way using Simplant, we've then been able to plan where we're going to put the implants. and we used a surgical guide in this case, and the surgical guide that you see there has been based upon the denture and a copy of the denture, a clear acrylic copy of the denture. This is the surgical guide in place, and this is using the surgical guide, and it allows us to place the 4 implants precisely where we've planned on doing this inside the mouth. These are the implants in place. This is after a period of healing. After a period of healing, again, we start the construction process in much the same way. We start it by taking a fixture head impression, and we can splint the impression post together. That's what you can see, and we've used floss initially to hold the implants in place, to hold the pattern resin in place. With this impression, we're able to then go digital, and during the digital stage, we're able to then make the CAD/CAM abutments in a digital way and parallel them and position them according to the height within the denture that we need to. When we've got the CAD/CAM abutments, we've then been able to then try these on in the mouth. Having tried them in the mouth, we've then been able to connect these up inside the mouth here using and when we've connected them inside the mouth, we've used a transfer jig to hold the abutments in place. These are the stages we go through. We've connected the abutments in place. We've used a transfer jig to do that. We've then connected the denture to these abutments using these gold components. These gold components are called taper caps, and we've been able to pick the denture up inside the mouth using this thing called Eufy-Gel, this material called Eufy-Gel. And what that's allowed us to do is to reconstruct the patient in a way that's predictable. So that's another option you can use for your patients. You can use these telescopic attachments in either an immediate or a delayed way. If you're doing it in an immediate way, you need to have a lot of stock around. If you're doing it in a delayed way, you don't need to hold much stock because you can CAD/CAM the abutments. You can use locators.
Locator, the versatile, all-inclusive over-denture attachment system from Zest Anchors. For over 40 years, Zest Anchors has been a global leader in the design and manufacturing of over-denture attachments, pioneering self-aligning attachments that make it virtually impossible to improperly seat an over-denture. Zest's locator attachment features a unique, patented pivoting technology. The locator's innovative ability to pivot increases the attachment's resiliency and tolerance for the high mastication forces an attachment must withstand, and allows it to compensate for the path of insertion, even with up to 40 degrees of divergence between implants. During seating, while the locator nail pivots inside the denture cap, the system's self-aligning design centers the nail on the attachment before engagement. These two actions in concert allow the locator to self-align into place, enabling patients to easily seat their overdenture without the need for accurate alignment and without causing damage to the attachment components. The locator system offers both locator nails and extended range nails, which are designed for maximum versatility in retention and angulation to suit each patient's needs. Locator nails allow for insertion of the overdenture with up to 20 degrees of divergence between implants and are available with 1.5, 3, or 5 pounds of retention forces. Retention force can be evaluated chairside depending on patient preference for level of ease of insertion and removal. Extended range nails allow for insertion of the overdenture with up to an extensive 40 degrees of divergence between implants and are available with 0, 1, 2, or 4 pounds of retention forces. Look closely at how the locator's pivoting action and self-alignment design allows the attachments to seat effortlessly. First, the rounded surface of the locator attachment allows the nail to center on the attachment before engagement, so it can easily locate its proper position, while the locator nail pivots inside the denture cap. These two actions in concert allow the locator to easily self-align into place. Once seated, the locator's dual retention feature provides a firm connection both inside and outside of the attachment, delivering twice the amount of retention surface area compared to others.
So, with locators, you've got different abutment heights, and the abutments will fit into the implants, obviously, and you've got a selection of different locator males and extended range males that fit onto those abutments. The difference between Syncone and locators is with Syncone, what you do is you use the different angles of abutments to line up the prosthesis. And what this means is you end up with 4 abutments that are pretty much nearly parallel, which means the force needed to dislodge them is fairly high. With locators, the angular compensation is done via the attachment, either the locator male, the normal range, the standard range, or the extended range males. There are a new series of attachments coming from locators, some of which are going to be out very soon. This is a case where we've used some locators, and what we've done here, what you can see here is the locators in place. And once the locators are in place, I've taken an impression, and this is an impression component that you use. This is an impression pickup that we've used. And we've simply been able to pick up, take an impression, send this off to the laboratory, and use 2 implants to restore this arch. I'm just going to skip through this. So there's lots of options that we've discussed with the maxilla and with the mandible. You can see in the maxilla we've got a choice of 6 or 8 implants. We've shown you a case with 8 implants and separate bridges. We've shown you a case with 6 implants fixed. We've shown you lots of cases with 4 implants. The mandible, again, the options are to use 4 or 6 implants to retain a full arch. And how about budget? In terms of budget, a high-end solution would be something like this. What you can see here is this is a try-in stage. This is the case I've shown you before, where we've made the lower fixed removable denture, the 2-in-1 bar. This is the try-in stage that we do. Slightly different try-in because we're aiming for a porcelain finish on here. And with this, what we've got during the try-in, what we're doing with this case is that's the try-in in place, and once we've tried it in and the patient is satisfied with the try-in, what we've been able to make is a framework, and the framework that we're able to make is something like this. So this is designed so we can use porcelain bonded onto the 3D printed, the additive manufactured metal framework. So this is the framework in place, and we will try the framework in place as always. And what you can see here is a higher end solution where we have used porcelain as the final restoration. So in terms of budget, that's a much higher and much more expensive. And with this, with the metal, with the porcelain in place, what we've been able to do is to achieve a nice result for the patient that looks like this. So this is the final result for the patient. That is obviously a much more expensive option for the patient, and in using this expensive option, it may not work for all of your patients, this sort of price range. What you may need to consider are different options for your patients. So when we look at the final options here, we can look at different materials, and we can get good aesthetic results with lots of the different materials. So what you can see here, different materials we can use to construct a full arch. We can use acrylic, and so here is a solution where we have acrylic teeth and acrylic gum. The next solution we can use here is one where we use, again, acrylic teeth and acrylic gum. And you can see really the relationship of the teeth and gum is such that the patients are, if there's a range of different options or a range of different prices for your patients, you can hopefully find something to fit into the budgets that your patients are looking for. You can also use composite, and this is a slightly more expensive option for your patients. But in terms of aesthetics, again, you're going up slightly in the aesthetic delivery, or the way that the final results will look for your patients. We can also use composite, and within this particular option that you can see, you can spend time customizing. Here, my technician Jamie Brain has done a great job here. He's customized, and he's customized the composite so that the gum tissue looks much nicer and looks much more realistic. And porcelain, again, tends to be the higher end option that we would offer our patients. So you can see how with a number of different implants, and with the numbers of different implants, you can offer your patients choices at all costs. So if we go back to this initial slide that I've shown you, what you can see here is you can, at the very lower end of the cost scale, look at 2 implants and an overdenture. At the very higher end of the cost scale, you can look at restoring everything with 8 implants and porcelain bridges. There's options in between, such as the 4 implants and telescopic overdentures, or 4 implants with locators. 2 implants and a bar. The reason for the increase in cost between this option and that option is there is actually more CAD/CAM milling required for that option, and that means that the cost, because of the external cost of using a laboratory, as well as using a, well, you would use a laboratory anyway, as well as manufacture of the bar, tends to push the cost up. Obviously, the more implants and the more units on the bar, the cost goes up. And you're able to, hopefully, if you look at the range of different options available to your patient, look at the different things you can do for your patients, and realize that there's a range of different price ranges that you can come into when quoting for your patients. The cheaper end for us, again, would be the 2 implant overdentures. The more expensive end would be the 8 implant fixed bridges. In terms of function, we discussed this again, where the different papers have looked at the amount of function that you can get. And interestingly, the amount of function tends to go up in relation to the number of implants, as well as the rigidity of the connection. So, for instance, if you've got a 2 implant locator overdenture, that will move around a lot more than having a 6 or 8 implant fixed bridge. What we tend to find is that once you get beyond a certain level of rigidity, and this tends to come with retention bars, and especially if you've got retention bars that have different shapes and ones that have a rectangular profile rather than a pear-shaped profile, you'll tend to get more retention for those particular implants. We're based in London, and these are some of the team that allow me to do the work that we can. So I've got to thank all of them, because without their work, what we're able to do would not be possible. You can find me on Facebook, on Twitter. I write a blog on WordPress, martinwenende@wordpress.com, on LinkedIn, and also newly on Instagram. So you can find me on all of those mediums should you choose to want to connect and to find out a little bit more about the sort of work I do. My practice is limited to implant and aesthetic dentistry. I've also got to thank the other partner in the practice, Nick Sisodia. So him and I have been limited implant and aesthetic dentistry. I'm also going to take the time to talk about a course we run, which is the implant restoration course, where we teach all types of implant restoration, not necessarily surgery, but we teach implant restoration. Now, thank you all for attending from all around the world. It's been great to speak to you. It's been great to have this chance to talk to you, and I also have to thank the people at Dentsply Implant for letting me do this webinar. I'm now going to hang up and let everyone get on with their evening, and thank you to everyone who's spent the time with hearing about this evening, and I wish you all a good evening. Thank you.